Hey guys, so today I'm going to be going over thromboembolism, which will cover deep vein thrombosis, venous thromboembolism, pulmonary embolism, and then heparin-induced thrombocytopenia. So let's first get into basically the definition. So thromboembolism, so venous thromboembolism, which is a VTE, is an obstruction of a blood vessel by a blood clot that becomes dislodged from another site. If that clot travels up the heart, so I'll just do a heart here. If it travels, I guess we gotta do, let me do a person here, there. I hope you guys like my drawing. Okay, let's say the clot starts here in the leg, and it's gonna travel all the way up to your heart. Then it can block the pulmonary artery, and this is what is known as pulmonary embolism, because which is life-threatening, and it can cause heart and respiratory failure. And a deep vein thrombosis is basically a type of VTE that occurs in the deeper veins, and that could be like something in the leg. So I think sometimes people get confused with DVT and VTE. DVT is just basically a type of VTE. Okay, so I think the best way to understand the risk factors and everything is to basically understand Virchow's triad, which is basically the formation of a clot. So first one is you're going to have stasis of blood flow. So this is basically increased time for the platelets to bind together and form that clot. And you're going to see that more in like bedridden patients or long travel in like a plane or car. Usually about an 8-hour plane ride or something is usually the minimum for a clot to form. Another one is hypercoagulability. So that's increasing coagulation and decrease in anticoagulation. So for example, that could be like heparin-induced thrombocytopenia, or estrogen use like YAS. So estrogen use would increase that procoagulation, and then HIIT is something like with the extreme version of anticoagulation. And then lastly, endothelial injury. So that's something wrong with the venous walls that normally stop the clot from binding as well. So that's causing the clot to travel further up. And that could be something like smoking or surgery. It's just important to know that pregnancy affects all three of these. So that's there's usually a higher risk of VT in pregnancy. So patient presentation. So if they have like a DVT, they're gonna have that swelling and pain, and they'll usually complain of like a hot feeling coming from their leg. Pulmonary embolism is going to be like your shortness of breath and pleuritic chest pain. And diagnosis, you're going to do basically a physical exam or imaging tests like CT and ultrasound. But this one will probably be like the key one, is a positive D-dimer test. And a D-dimer is basically a protein that breaks blood clots, and a high amount in the body means a clot is present. So in a normal body, this is the protein that will break down a blood clot. So treatment, a majority of the treatment will be symptomatic, like Tylenol or opioids for pain, but you're not going to use NSAIDs like Advil or naproxen, because they increase the risk of bleeding. And then graduated stockings can help prove edema and pain, but they have no efficacy in like prophylaxis of VTE. So these are basically going to be your main three treatment options. Number one is going to be 5 to 10 days of using like a low molecular weight heparin or an ultra unfractionated heparin or fundoperidone, which is a factor 10A inhibitor, and then dabigatran or edoxaban. So just to note, these are all parenteral injections. The next one is going to be like warfarin, same thing, warfarin, but this time you're going to give it along with the 5 to 10 days of the parenteral injections, and you're going to do it till at least your INR is greater or equal to 2 for 24 to 48 hours. And then you can use warfarin on its own. So just to note, basically the first two options are going to be like sort of like, you can think of it as like a bridging therapy. I'm going to put BT for bridging therapy. And then your third option is just going to be apixaban or rivaroxaban on its own. And the reason for that is because they have such a quick onset of action that you don't need to do that bridging therapy. So the pros of using DOACS, which is like your apixaban, rivaroxaban, dabigatran, and edoxapan, is you don't need to do lab monitoring. So it doesn't need lab monitoring. Where warfarin needs lab monitoring of the INR, which needs to be between 2 and 3. But a pro of using warfarin over DOACS is that warfarin can be used in renal impairment or special conditions like valvular atrial fibrillation. The DOACS can be used in renal impairment in certain cases. So apixaban can be used in creatine clearance of less than 15, where the other three, it can be used up to creatine clearance of 15, but nothing lower than that. And then the rest can only be used at least above a 30 mils per minute for creatine clearance. Okay, so this is going to go over basically the prophylaxis. So this isn't orthopedic, so that's going to be like something like your knee surgeries. So you're going to use apixaban or rivaroxaban, usually given 6 to 12 hours post-surgery and continued 14 to 35 days after. You can also use a low molecular weight heparin, like enoxaparin, as an alternate. And if the patient knows an aspirin, it can be resumed after 5 days of the rivaroxaban or 10 days after a low molecular weight heparin. And that's just to decrease the increased risk of bleeding. Because if you add on the aspirin, you increase that risk. Non-orthopedic prophylaxis. So you're basically not going to use your DOACs. You're usually just going to stick to your heparins. Pregnant patients, you usually want to use your low molecular weight or unfractionated heparins, as it does not cross the placenta. You can also use fondaparinol, or if there are not any other options. And treatment is going to be minimum for 3 months to 6 weeks postpartum. A really popular one in pregnancy is usually going to be like your enoxaparin. That's usually the popular one you'll see. So renal dysfunction, so this is what I went over earlier. So apixaban will be the one that you can't use less than 15, where the rest you can't use in less than 30. Heparins will also require kind of renal dose adjustments. So they can still be used, but they'll just need to be adjusted at those doses. Warfarin, however, doesn't need to, only needs to be adjusted by the INR, so you can use it in any kind of creatine clearance because it's usually the preferred one in renal failure, as mentioned earlier. Okay, now let's say the doctor wants to switch over from warfarin to DOACs, usually because warfarin is usually not as popular anymore, and DOACs is usually the ones that are usually the preferred treatment. So you'll want to, so this is kind of where it gets a little bit confusing. So for something like apixaban and dabigatran, you want to aim for an INR less than 2 before stopping. But if it's rivaroxaban or edoxapan, they can be switched in an INR of less than 2.5. But honestly, just go with the 2. The 2 just kind of keeps it simple. If you know it's 2, it's going to be basically the switch. Okay, so this is a life-threatening side effect of heparins. And it can occur in the last 5 to 10 days of the heparin exposure, and it's more likely to occur with your unfractured heparins compared to your low molecular weight heparins. And basically the patient will present with like numerous bruising and thrombosis, but you rarely see bleeding, but they will be more susceptible to bleeding. So you're going to see basically a 50% drop in platelet count and a positive HIT antibody. Usually these patients will still be in the hospital when this happens. And that's usually when they catch it. So treatment is usually stop the heparin and start a non-heparin medication, and it's going to depend if there's a thrombotic event. So if there's no thrombotic event, and let's just say like something like prophylaxis, the duration of the treatment is only going to be like for 4 weeks. But if it is like due to some kind of thrombotic event, like a DVT or VTE, PE, it's going to be for 3 months. So you're going to use direct thrombin inhibitors, argaroban and bivalirudin. Honestly, you probably won't even see these two as much. The only problem is probably see them in HIIT therapy, basically. And they are IV, and they're going to require frequent monitoring. But the pro of this is you can use it in renal impairment. Just note that if the patient is already on warfarin, argaroban will falsely elevate those INR. So for example, when might you see in a situation like this? Well, it would probably be like those treatment options we talked about, where you use the warfarin plus the parenteral anticoagulants for at least 5 days or until the INR is about 2 equal to 2 for 24 to 48 hours. And then lastly is going to be your DOACS, and then of course you're going to go with the Pixaban or Rivaroxaban, and because they've got that fast onset, right? And the pro of using these ones is they don't require lab monitoring. However, you have to be careful in renal impairment and CYP interactions as well. And then the last one is fondaparinol, which is selective factor 10A inhibitors, which is a subcutaneous injection. This one is preferred because there is no lab monitoring, although you should still avoid it in creatine clearance of 30 mils per min. But the pro of using this one over a DOAC is it's not affected by CYP interactions. And it's also the subcutaneous injection, because maybe in some scenarios they'll say that a patient doesn't want to do like IV or anything. So you can get away with just doing like an SC injection. Okay, and then just some random notes I thought I would add. So dabigatran is basically going to be like your only DOAC. This dabigatran is probably the one that you're going to see like just weird questions on. So this is the one that's not affected by CYP interactions, but it's affected by PGP inhibitors, something like phenytoin. So phenytoin also is a CYP inducer, so it also affects PGP as well. So that's also going to affect your dabigatran levels. And I can't really think of PGP inhibitors off the top of my head, but phenytoin is the one that just comes to mind. Actually, now that I'm writing this, now I'm like, is colchicine one? No, I can't remember anymore. Anyways, it also needs to be dose reduced from 150 milligrams BID to 110 if the patient is greater than 80 years old. And then edoxaban should have the dose reduced to 30 milligrams if patient is less than 60 kilograms. Rivaroxaban, 50 milligrams, 20 milligrams, they should be taken with foods for better absorption. And then heparins can also increase the risk of osteoporosis, so you got to watch for that falls risk, and that's why they're not usually used long term as well. And then, of course, like your adverse drug reaction for all the therapies is going to be an increased risk of bleeding and bruising. Dabigatran is the only DOAC that is most known for causing the dyspepsia. And then warfarin can also cause that skin necrosis and hair loss as well. Okay, and so that pretty much covers your VTE, and pulmonary embolism. I really hope that helped you guys as well. It's a bit of a kind of, I guess it's kind of easy, kind of hard kind of lecture. The problem is you just have to remember like the dosing and stuff and what is important, whatever. But basically you just gotta know like DOACs pretty much are going to be your key players in this, along with your heparins. So whenever you think like VTE, you should probably think heparin and DOACs. Any kind of anticoagulant therapy. Very rarely you're going to use antiplatelets for this kind of condition as well. All right, guys, good luck, and hope you do well in your exams. Thanks. Bye.